I'm so happy to have both of you here today to talk about a topic that I think is rarely discussed, and that's small cell lung cancer. And so I'd be really interested in your kind of laying out for the audience, what is small cell lung cancer and how's it different from non-small cell lung cancer? Um, do you want to take that, Jacob?
Sure. So, just broadly, cancer by definition are cells with mutations that have them stuck in an on growing and dividing pace. And small cell lung cancer tends to be so looking at under the microscope, these are smaller cells, which initially led to the difference between small cell and non-small cell. Of course, there's a lot more we know now about different cancers and non-small cell now has been separated into other smaller subsets, which is beyond the scope of this discussion. Small cell lung cancer, we also now know that there are certain genomic alterations to the DNA that are common. So things like P53, things like RB1 are very common in this cancer type. And those are essentially things that within the cells that are growing and when they're in the process of replication, growing and dividing, these are things that help the cell to pause to repair mutations. And so these are often mutated and non-functional in small cell lung cancer, which just keeps it growing and rapidly dividing. It's like the brakes on a car being broken. So broadly speaking, small cell lung cancer tends to be a lung cancer type that is often very aggressive. It often grows more quickly. It often also shrinks more quickly with chemo and radiation. And so the implications of that are really kind of probably something we'll get into a little bit further.
Yes, definitely. So, Catherine, um, I know small cell lung cancer often is thought about as the smoker's lung cancer. And so, with that kind of concept, there are a lot of issues around stigma. I wonder what your thoughts are, or what your experience is with patients around stigma or their own feelings of guilt if they did smoke. Can you talk about your experience with patients around those issues?
Sure. Yes. As you said, small cell lung cancer within lung cancers is most commonly associated with patients who have smoked in their past or are currently smoking. I think one thing it's really important when I'm talking to patients, and something I've learned over the years from mentors is, you know, anyone with lungs can get lung cancer, and I think that's the most important place to start. Is that we all have risk factors for different types of cancer, but that's the bottom line. And I think once you have someone in your office who has a diagnosis of lung cancer, it really doesn't matter, what brought them there. The point is to think about how to best take care of them moving forward. And I think it's really important to support patients and say, if you are still smoking, here are some resources we have if you're ready to quit. And, this is not your fault. None of this is your fault. And so I think it's important to both have the research and understand, how people might be at risk so we can catch things early, but then also know that it really is just a risk factor, and it's important to support patients both through that and through their lung cancer diagnosis.
Well, I was diagnosed with lung cancer in 2007. It was just by accident. And fortunately, it was 1A, which means it was super early, just by accident. It just was what it was. But I do know that when I went to the hospital, I just had surgery and that was all. But when I went to the hospital, they give you all these forms to fill out, name, rank, and serial number, and all that stuff. But one of the questions was, do you smoke? And I thought at the time, holy cow, if I had to put down that I smoked, I would just want to dive out a window because it just felt so shameful.
Mm.
And so I don't know, Jacob, do you experience that with some of your patients who feel like, oh, I smoked or I'm smoking and it's, my fault. I feel so guilty for doing this. It was, you know,
Yeah, this is a huge topic. It's really hard to sum, to your point, actually, I very commonly hear patients say that when they tell people that they have lung cancer, the first question is, well, did you smoke? And people say yes, and they often are met with, oh, I mean, implying exactly what you're saying. And I think as a society, um, over the last few decades, in the efforts to try and help or push quitting smoking, in demonizing smoking, the people who smoke got wrapped up in that too. And there are a lot of people that started smoking at a very young age. The advertising, the culture, I mean, everything is kind of pushed people into smoking at young ages, and especially people who started smoking decades ago. I mean, this is, there were doctors smoking in the infusion room decades ago. I mean, it's crazy now to even consider that. But there are a lot of people that started smoking at that time as well, and this is incredibly addictive, and it's very hard to quit. Um, and so one of the first things I do with people when they're diagnosed, there's so much swirling in many of their minds, and so this feeling of guilt, it just doesn't help. It kind of adds to all of it. And so one of the first things is exactly what Dr. Meador is saying, helping them get their feet on the ground. The past is now the past. Here we are. Let's focus going forward. You are supported. We're going to do everything we can. You deserve good outcomes. And no matter how we got here, this is where we are. How do we move forward? And I have some people who smoke who also don't want to quit. And I don't shame them for that either. I think it's important to say, um, that we're going to support them no matter what. And for those who are interested in quitting, there are a lot of people that want to be there to help them and to make it an easier path. But it is very difficult to quit, and so we support people where they're at, no matter where that is.
I was going to say two things. So, Backstage at Upstage, which is our podcast, has a wonderful podcast on stigma with Chris Draft. And so I would just urge everybody to tune into that podcast because it talks a lot about where this all started and the whole smoke out and then how that turned into stigma. The second thing I wanted to mention was because upstage lung cancer is unique in that we use music and the performing arts to raise awareness about lung cancer and fund early detection research. Years ago, I produced a show and we were looking at early television. So one of the things that I looked at was some of these early advertisements, and there was something called the Camel News Caravan I think it was in the 50s. And so in that commercial, they have a doctor, white hair, sitting kind of on the edge of his desk with a cigarette in his hand, talking about how Camel cigarettes are going to be good for you and clear your throat and make you feel better and all of this kind of stuff. So if you Camel hears this podcast, don't sue me. Anyway, it was just a mark of the times. So absolutely.
I was just going to add, and I'm only here to reflect on some of the things you're saying. And you have a question on your list of questions about statistics, and I'd like to get the docs to respond. But in your case, Hildy, maybe you can start. Was all that information, the WebMD world, whatever it was at the time, was that just so stressful and overtaking at the time? How did you deal with that, and how do people generally react to the quote unquote stats that they're seeing everywhere?
Well, I think so. One of my other hats is as a psychologist. So I try to be effective and efficient for all hats that I put on. But as a psychologist, I would just say that people react very differently to their diagnosis, which I'm sure both of you could speak to. And so I'm usually somebody, if my nail polish is chipping, I will go online to see why and what and how to do better. When I was diagnosed with lung cancer, I decided I didn't want to look at anything. And all I wanted to do was get the most effective physician that I could push for questions and make sure everything made sense. But that's what I needed to do for my own nervous system. But my husband, of course, looked up everything on earth. So, I think people react to these diagnoses, especially with lung cancer, in the way that is most helpful to them. But hopefully one way or another, they can get information.
So how do you each handle that when people are first given the diagnosis, Catherine?
Yes, I mean, I couldn't agree more. I think everyone is very different in that moment, and certainly always hard for us to put ourselves in the shoes of patients. But I think it's really helpful. I have found initially when I'm meeting a patient to sort of get a sense of what's helpful to them and where they're coming from. Some people really like numbers and statistics. Some people don't, and I think both of those things are great, and it's helpful as their doctor to be able to meet them where they are in that sense, because having the numbers at the ready and sharing those with folks who find that very helpful, I think, is important. We always, also add the context that every patient's an individual, so we can give numbers and stats. But I think the other important thing is recognizing that every patient's course is going to be their own. And so giving them a sense of what's out there, and then also a reason to sort of hope in their own right is a good thing. And then I think it's really important to understand the patients who say, I don't want those numbers, I don't want those stats, but I just want to trust that you're going to, take care of me and share with me when you feel like there are important changes going on, because I think there's a way to both be honest about that, as well as respect their sort of comfort level with the level of discussion. So everyone is very different, I would say.
I wanted to support your position with what you just said, because that was exactly my other hat is I'm a researcher. And so one of the things I say all the time is it's an N of one, which means it's just an individual. So if they say 30% of people with small cell lung cancer X, or 50% of small cell lung cancer Y, where do you as an individual fit? Those aggregate numbers are interesting and they do tell us something, but if you're looking for your own treatment and your own directions and choices, it's really about you. And that's why I think if you're fortunate enough, and that's what I would encourage everybody to find, the very, very best, most knowledgeable and good match in terms of personality physicians, so that you can just work those things out. So
Yeah, that's a really big point that both of you are making. The most common question we get is essentially, what's going to happen for me? People want to know what their course is going to be, and the truth is you can't tell them. So one is I reassure people that I will be as blunt and as direct as I can possibly be. I don't ever want people to have to be reading my facial expressions to try and guess what I'm thinking. I'll just tell them what I'm thinking. I will say blunt and difficult things to say, but that's at least how we can then discuss it. And I think when people feel reassured by that, then when I'm saying that things are good, they also are truly reassured by that. And not worrying that maybe I'm just saying something. So one is being really blunt, but the other thing is that word cancer carries so much. And so people come in with this huge bag of beliefs and expectations. And one of the hardest jobs as an oncologist is to try and read where people are starting in this journey, where their mental space is to begin with, so that we can discuss it in a way that's most helpful to them. Some people come in with this idea that, actually, I frequently say this directly, especially when we're talking about chemotherapy. I say that many people think that when they get chemotherapy, they're just going to be laid up in bed vomiting without hair. And I say that as a starting point, and really the majority of people nod and say that's exactly what I've been picturing. And I say, okay, well, I don't expect that. I mean, for non-small cell lung cancer, the most common regimen we're using, people don't lose their hair. And even something like that I think that losing hair is not life or death. But losing hair is a huge deal to people's perception of themselves. And I think it goes beyond their hair even. I think by their hair falling out, they now look more like that sick person with cancer that they picture. And it's about how much it's strengthening their preconceived ideas of that they're someone who's sick and dying. And there are patients that do exceptionally well, and I have a number of people that tell me once they're into their treatment a ways, things are going well. They say, hey, I've had days where I don't even remember I have lung cancer, which is a huge thing for someone,
Big
especially
thing.
undergoing treatment still. Not someone who's years out from curative treatment, but someone who's undergoing treatment to say this, which is to say that we've come a really long way on our therapies, and there are subsets of groups that have exceptional responses to treatment, and it's not everybody, and there's a lot more for us to do on the research side, but helping people to understand that those exceptional possibilities that exist, I think, is what Dr. Meador is referring to in saying, where the hope is in this process is that there are people that really do legitimately have extraordinary outcomes, but how to help people kind of first break down some of those preconceived ideas of how things will go, to then allow us to say, okay, that now that, don't hold those expectations, where are we starting and what are the possibilities going forward. But I don't tend to give people real numbers, because what I've found is that when I even explain all of exactly what both of you are saying, the N of one, people still hold on to it. And months later, they'll say, oh, well, you said I had this much time. Oh, no, I never say that. I just think it's too hard for people to not grasp that number with everything. So I'd say to them, hey, are we making decisions here? Is there a decision you're making based on this discussion, or you're just wanting to know how things will go? Because if they want to make a decision, if there's something about their lives, then we need to weigh out the risks, benefits of kind of all aspects of that. I had a guy years ago who, when I had seen him, it was 4 years into his treatment, and he had sold his boat when he was diagnosed, because he just, like, he had cancer, he was going to die. In his mind, that was and 4 years in, he was saying, man, I really wish I hadn't sold my boat. What a bummer. I really love that, and I wish I could go out in that. And so if people are making decisions, then we need to discuss. If not, then I think the most important job is to help people to feel okay with not always feeling okay, or to not feel anxious about feeling anxious. That it's okay to feel anxious. It's okay to feel scared. All of these negative emotions are part of the process, and not necessarily trying to cover those with anything either. And that discussion, as you know, Hildy, as a psychologist, is very personal. It's to each individual, that discussion happens in a different way.
Well, that's right. And people's definition for themselves, their own self-definition of what life is and what has meaning. Yeah, it varies tremendously. So as far as diagnosis of small cell lung cancer, disentangling it from non-small cell lung cancer, have there been any changes in the diagnosis of small cell lung cancer in the last bit of time, whatever that is?
I mean, I think in terms of diagnosis, so as Dr. Sands alluded to earlier in our discussion, unfortunately, small cell lung cancer is typically kind of a faster growing cancer. It is harder to catch early, at least with our current screening methods. Of course, we hope that early detection gets better and better over the years, but right now it's more often diagnosed at later stages, and so that's, rather than being picked up on a screening CAT scan or something like that. That being said, even our current screening efforts are getting better and better. We have a long way to go in terms of, getting everyone with those risk factors into the clinic and getting their yearly CT scans, which is the current standard of care. And I think, with progress there, we are catching some small cell cancers earlier, and learning a little bit more about what's the best way to treat those small cell cancers that are caught early. So I think my sense is we have a lot of room to go on that, still, but the hope is to be able to catch them earlier. And then I think a lot of the progress in recent years has been in, better and better treatments for later stage disease as well, if the cancer's picked up after it's spread outside the lungs.
I was going to just mention for the diagnosis or detecting it early, it's important for people who are listening to know that Medicare We'll cover those screens for a variety of people, and maybe Jacob could say a few more words, but also there's a lot of pressure. I know upstage lung cancer is a part of a consortium called LungCan, and we've been pushing and writing letters, and there are organizations who are pushing for earlier screening to be available and covered by insurance.
Yeah, I'd say, I mean, lung screening cannot be overstated. It really is, has the potential to impact all cancer mortality more than anything out there. Lung cancer, unfortunately, kills a lot of people. And through lung screening, we can really save the majority of individuals that are undergoing screening. Or I should say, the majority of people that would die from lung cancer but qualify for screening can be cured through the early detection of lung screening. So for anyone listening, if you qualify for lung screening, this is the best thing you can do to reduce the likelihood of you dying of lung cancer. That and some people, are concerned about getting scanned because they're afraid of getting diagnosed with a lung cancer. But the truth is that you get diagnosed with an early stage 1 lung cancer, you get surgery and you're done. Or in some cases, radiation if surgery is not an option for any reason, and you're done. Versus you wait a year or two, and that ends up being a stage 4, and now we're talking about how to really just control the cancer for as long as possible. So the earlier detection is the most critical. There are a lot of resources out there. There's another website by the American Lung Association, savedbythescan.org. That's savedbythescan.org, and that has a calculator on there as well, so people can who are listening can go on and plug in some numbers and see if they qualify or their loved ones qualify. But lung screening is overwhelmingly important. The other diagnostic thing for small cell, just to mention, is that people who do not have a smoking history that get diagnosed with small cell quite skeptical of that truly being small cell. And those patients should all get genomic testing also. Just like with non-small cell lung cancer, with small cell, that's a rare scenario. But I have seen patients that do have an actionable alteration and was probably more of a non-small cell variant that just the biopsy we got looked like small cell. Cancer by definition are cells that are mutated. So we put them into specific boxes, but they don't all fit beautifully into those boxes. And so rarely we do see patients without a smoking history that I think is more of a non-small cell. And so those patients should all get the DNA testing, cancer DNA testing that we see with non-small cell also.
It's interesting. I spoke with a wonderful young woman who was diagnosed with small cell lung cancer at age 28 and had not smoked. So your point is kind of interesting. Whether I don't know enough about the details of her, diagnostic experience, but it just says that nothing's 100%. You can't say if you never smoked, it's impossible to get small cell. It's again back to N of 1. So maybe there are very few people in that category, but it's possible. And the other thing I was going to say is it's about advocating for yourself. And so if you don't fit into an obvious category, you're 75 years old, you've smoked for 40 years, you've had a cough for, quite a while. Maybe there are other things you would add to that profile. Obviously go to your doctor. First thing they think of is, well, let's just screen you for lung cancer because that makes sense. But there are so many people who wind up with lung cancer who don't just neatly fit into this picture. And so I would just say to anyone who's listening about yourself or a loved one or someone you work with, if you have genuine worries or concerns, to push for getting, a really careful evaluation and not have it dismissed. I've talked to so many people who have said, oh, the doctor said it couldn't possibly be lung cancer. Don't worry about it. And 2 or 3 years later, they have advanced stage lung cancer. So This is not to scare anyone. This is to say, advocate for yourself.
Well, and
Certainly.
the other part of that is that, for most patients, initially they're treated for some kind of infection, or they do some. That's the most common, is they'll get some antibiotics, and it persists. And that's because for the majority of people, that initial treatment works. And so you don't want to initially start out doing invasive procedures on everybody.
Right.
So the big thing is that if it didn't go away with that initial treatment, it's not that the doctors were done. It's that they're giving you the treatment for the most likely thing at that time. And if it continues to be an issue, then they're assuming you will continue to let them know that there's an ongoing issue. So it's not just a one-off and then all done. In medicine, you're doing what's the most likely, what's the least likely to hurt somebody, and then if things are persisting, then things will get more and more invasive, such as getting a biopsy. And so it's really important to continue to be on top of your own health.
I have a question. Targeted therapy is very much in vogue, and it's a great topic for all cancer study. But how does targeted, whether it be radiation or chemo or whatever, targeted therapy fit in with the current treatment plans that you are both employing? We'll start with Catherine, Dr. Meador.
Sure. So you're absolutely right. And I think the explosion of targeted therapy options in the last decade or two within lung cancer has been really exciting, and has really changed the landscape of treatment of lung cancer. For small cell specifically, I would say I think there's been a lot of recent advancements in terms of preclinical research. So kind of not approved therapies yet, but a lot of interesting work looking at different subtypes of small cell lung cancer, and think a lot of smart people looking into how we target different, subsets, in the sense of right now and historically, we've just treated all small cell lung cancers as the same. We know based on other solid tumors and what we've learned over the years that that is unlikely to be the case. Most likely, there are separate groups of small cell lung tumors that are going to respond differently to different therapies. And so I think it's really important as we move forward to learn what's the important information at diagnosis to help us target certain therapies. Right now, just in terms of, when a patient comes into the office and is diagnosed with small cell lung cancer, the treatment decisions are based on them having small cell, and they're pretty standard across the board. But I think, there's a lot of exciting trials and things going on looking at targeted agents. And so my hope is that that will be the next phase of small cell. Dr. Sands, you may have other thoughts to add on that.
Yeah, so usually when we're talking about targeted treatments, and what Dr. Meador is talking about is these are drugs that really hit specifically cells that have something. And in non-small cell lung cancer, when we talk about targeted therapies, it's usually different DNA changes that indicate a receptor is a different shape, and so a drug can hit that unique shape. So it's hitting just the cancer cells without hitting normal cells. Now, within small cell, I mentioned that if someone does not have a smoking history, it's important to do that cancer DNA testing. And that is because there are some people that I think it's more of a non-small cell where those targeted treatments that are already established for non-small cell are an option. In small cell lung cancer, we don't have any approved targeted therapies in that same kind of a way. And so there are, as Dr. Meador is saying, there are trials underway with different receptors, like DLL3, for example, is a receptor on small cell lung cancer that we can potentially hit. The drugs are really usually using that more as a way of getting the drug into those specific cells, or bringing those cancer cells with DLL3 together with the immune system to create more of an immune response, which is a little bit different than the mechanism of the targeted therapies within non-small cell lung cancer. But it is a nice step if it pans out, and this is in trials, so we'll see.
And so what about immunotherapy, which is another exciting area in cancer treatment? What about that for small cell?
So immunotherapy in general is a very broad term, and it's a field, there's lots of different types of treatments that can be considered immunotherapy, whether it's, cancer vaccines or some of those targeted therapies that Dr. Sands was talking about. The most common thing we're referring to when we say immunotherapy is something called immune checkpoint inhibitors, which have been approved for lots of different types of tumors, including non-small cell lung cancer and small cell lung cancer. So actually, that was probably the biggest addition to general small cell lung cancer treatment over the last 5 years or so was the finding that adding one of these immune checkpoint inhibitors or immune therapy together with chemotherapy from the beginning actually leads to better outcomes for patients. So now that's the standard, and that's been an exciting little bit of progress recently. And so that's also being tested, now that we know it's helpful in those in the metastatic small cell lung cancer. It's being tested in different clinical settings, and we're trying to figure out where are other potential uses of this, and also which are the patients that are most likely to respond. I think that's the most important next question, because there are some patients anecdotally who have really durable responses to this immune therapy. It's not a large number of them, but for those that respond well for a long time, that's really exciting. And so we need to try to do better at figuring out who are those patients that can benefit most.
So what would you say, Jacob, what's exciting in small cell lung cancer research now? What's going on that would give a different direction or a broader direction in this area?
Well, I think the most exciting thing right now is that there's so much happening. For small cell lung cancer, we have very few FDA-approved therapies. We did recently have lurbinectedin added as second line as well, along with topotecan. Those are really the only FDA-approved treatments. The other drugs, though, that commonly used ones still, paclitaxel, irinotecan, temozolomide sometimes, these drugs have been around for a long time. And so there hasn't really been so much happening in small cell lung cancer like there has in non-small cell. The last 13 years for non-small cell have been absolutely revolutionary, with a number of new targets, a number of new drugs. Small cell lung cancer hasn't had all of that. It's had the immunotherapy that Dr. Meador mentioned, and lurbinectedin. But now there are so many other things in development, different pathways, different mechanisms. I mentioned a couple of different ways of using DLL3 as a receptor for drugs in trials, aurora kinase pathway. There are a number of others. So I am particularly interested in the immunotherapy stuff that's happening, where like binding DLL3 and binding the immune system to then create more of an immune reaction. I think that's an exciting mechanism. We'll see how that pans out. The immunotherapy that is currently approved, that Dr. Meador was mentioning, it's a subset of patients that really benefit, but those who benefit unbelievably. I mean, I have people that are more than 3 years out from their initial diagnosis of small cell lung cancer, where it was widespread. So this was not curative treatment, but they get the immunotherapy. Generally, I stop at 2 years and then monitor with scans. And I have people that are more than 2 years out, where we're just doing scans every few months, and I call them high five visits, where they come in and everything still looks good, and we schedule another one 3 months later. Are there some of these individuals that aren't going to have cancer show up in 10 years? I mean, we don't know. And the fact that we don't know is pretty remarkable. So that that kind of thing, we need to help happen for everybody. And so this other immunotherapy I'm particularly interested in, because we are seeing some signs of there being some nice responses to the treatment. We don't yet know about the durability. We don't yet know about how many. As mentioned, it's still in trials, but if we can get that kind of home run for more people, then we're taking really legitimate steps forward for those individuals. Most of the drugs developed historically, when we're talking about chemo drugs, these are drugs where I liken it to a baseball analogy, if I may, but where you're swinging for a single or double, and you get a lot of hits, but it doesn't necessarily win the game itself. You need a bunch of drugs where you're getting singles and doubles. These immunotherapy outcomes are more like swinging for the fences. It is swinging the bat hard, and unfortunately, most strike out. So that is the downside. But when it connects, home run. And it is really changing the practice of oncology as well, to have some of these individuals where you just follow them for years with such remarkable outcomes when things were so challenging at the get-go. So more of that kind of outcome, more home runs is what we're really going for. In the meantime, we'll take all the singles and doubles we can get.
Well, I love that. And that sort of brings me to kind of where I wanted to end up with this conversation, which has been so remarkable. And that is, where's the hope with small cell lung cancer? What can you say to patients, to families, to the general public about what the hope is for small cell lung cancer?
I guess I can start. I would say, as we sort of already referenced in our conversation, it really is not overstating it to say there is so much exciting work going on in the research sphere within small cell. And you could say, oh, well, it's been decades since we've had a major, new home run, as Dr. Sand said. But I think there's some really important differences over the last few years and moving forward. And some of that has to do with just our technology is getting a lot better. So historically, small cell was harder to study because we need some tumor tissue to be able to do some of these analyses. And we often got smaller biopsies and less surgeries and things. But just that what we're able to do on small pieces of tumor tissue now in a research setting, and what we're able to do non-invasively in terms of liquid biopsies moving forward, I just think the field is going to explode in that sense. And that information just, leads to hopefully, and I think very legitimately, new therapeutic options. I think it's very, very reasonable to have hope for better small cell treatments moving forward.
One point I always make with patients is that I'm not going to talk about hope just for the sake of hope. I know we have a lot of kind of focus on what is the hope, and it's an important question. But I just want to clarify, for individuals coming in, I think it's important for them to know that I'm just giving them everything straight, and we're not just trying to. But there is a lot to look forward to in this, and so one is that anytime we're looking at the numbers, so people who do go and do their research, they're seeing how things have been behind us. But science is speeding up so much, and there are so many drugs in development. And as mentioned, I have patients who are now many years in on immunotherapy that's because they started on a clinical trial with immunotherapy before it was ever approved. So they're really years in. And with all these drugs in development that are in trials, that means people who are going to centers that have trials available are getting some of these potential future options today. And so the outcomes that are going to happen for anyone diagnosed now are really related to what's happening moving forward, not what's happened behind us. Dr. Meador also talked about a new framework of looking at small cell and potential subtypes, and that's something that might also help us to utilize each of these drugs in development even more effectively and better as well. So this is, as far as small cell goes, we're in kind of a revolutionary time of a lot of science going on, and hopefully many of these will pan out as being effective treatments going forward.
I was going to say what I've learned about lung cancer in the 15 years since I was diagnosed is keep living, because the longer you live, the more new drugs, new procedures come out. And for me, that's hope. And also Backstage at Upstage also had another wonderful podcast on clinical trials. And so it's important to know that there are trials out there that people are researching, they are trying to do better and keep people alive longer. And the last thing, a shameless promotion from Backstage at Upstage. Our first podcast was called Finding Joy. And it sounds like it's kind of a, antithetical to think if you're diagnosed with lung cancer, there's going to be joy. But really, I think somehow, and it could be in small ways, it could be telling someone you love them, or it could be listening to a Frank Sinatra tune, or taking a walk, or something else, but finding joy in the day, making life matter as much as you can while you're facing difficult times. So
Couldn't agree more. And she does do shameless plugs, but I'm glad you doing that, because this podcast today, thank you both, has really elevated what we're doing with so much great information. So Hildy, you deserve kudos for lining up these two hard to book guests.
oh, well, Catherine, it's so nice to meet you, and I look forward to many more times together. And Jacob, my heart. He has my heart and has for a long time. He's just a wonderful, wonderful human being, and any of his patients are lucky to have him. So thank you both. Thank you, Jordan, as always. And we look forward to more podcasts and more conversations about lung cancer, which is not usually something people talk about. Our goal is to make this more of a conversation. It's okay to talk about lung cancer. So thank you.
Thank you so much, Hildy. It's inspiring how much you're doing. I really appreciate all the work you're doing for so many in this community. It's really wonderful. So thank you for having me on.
Couldn't agree more. Thank you. It's been fun.
It was wonderful. You guys sounded great, both of you. There were a couple of little pauses that I'll fix. I was making notes, but that is awesome. Thank you very much.
It was great.
Yeah.
Thank you both.
And
I thought it went
you'll
really
let
well.
them know when it's up.
Of
and
course I will, because
links
I'm
and-
going to make them promote it. Are you kidding?
Of course. What am I saying? All
What
right,
do you think?
we've got to run. I've got another 10 o'clock interview coming up, but thank you both. God bless
Thank you so
both for all the
much.
fine work you're doing. Happy New
Thank
Year.
you.
It's not too late to say
All
that.
right.
Okay.
Take care.
Bye.
Take care.
Bye now.
Bye.